This is just the beginning.
Welcome to another Vitals Checkup virtual event, our monthly series spotlighting the most pressing healthcare issues and trends. I'm Tina Reed, Axios healthcare editor, and I'm joining you from Washington, D.C. Thank you to UnitedHealth Group for making this conversation on strengthening care accessibility and the future of providing care possible. Welcome to our audiences on Facebook, YouTube, Twitter, LinkedIn, and on Axios.com. You can join the conversation on Twitter with @Axios and #Axios events. Over the next 30 minutes, I will be joined by my colleague and senior editor, Sam Baker. We will unpack how the pandemic has shifted the conversation around access to care from telehealth to evolving hospital operations and take a closer look at strengthening care accessibility and the future of providing care. Up first is the administrator of the Centers for Medicare and Medicaid Services, Chiquita Brooks-LaSure, joining us from Washington, D.C. Welcome, Administrator.
Thank you. It's a pleasure to be here with you.
So you have been on the job for about a month now. What have you been spending the most time on so far?
It's been such a pleasure to be the CMS administrator, and what an honor and a privilege. Most of my time, I would say so far, has been spent getting to reconnect with the CMS staff, who are among some of the finest federal employees in this country, and just getting up to speed on all the work that is going on and jumping into supporting the Affordable Care Act.
Now, you are coming to this role with quite a bit of public service under your belt, but you're also joining when we're still in the midst of a pandemic. How does that change how you have to think about the role and what you're prioritizing?
I think that coming from a pandemic, and we are still in the midst of it, although so many wonderful signs of people getting vaccinated, it has really helped really focus on making sure we are prepared for the next public health crisis, really making sure that our country we strengthen our coverage. And so we at CMS and I have been very focused on making sure that coverage is accessible. We are really seeing incredible gains in health insurance coverage. And I think it's because people are realizing it's how important it is, and people will sign up when you make it affordable. We're also very focused on advancing health equity. So the disparities in our healthcare system are longstanding. They are not new. They are generational. But we have a moment because the country has seen what happens and what these disparities look like up close and in stark reality, in painful realities. And so we are really focused on making sure that all of our policy initiatives are really focused on advancing health equity, and is really a particular moment in time that we need to take quite seriously.
Can you talk a little bit more about some of the examples of concrete ways you can really dig in on this health equity issue that we did see?
It comes, I would say, in multifaceted ways. So the first way that we are really focused on advancing health equity is making it the first question and not the last question. So every single policy that is coming to me, the team knows that I'm going to ask about health equity. So they automatically start talking about how whatever the policy initiative is, how we're going to build in health equity, whether it's making sure that we're collecting data so that we can make better decisions, or whether it's just making sure that we're looking at the policies through that lens. And as we start doing it, the policies improve. And, I would give one specific example, maternal health, which has been a focus of mine the last couple of years. It's incredible when you actually take a good look at the data at where the deaths occur. They don't just occur at the time of delivery. They occur a couple of months later, many of the deaths, because it's a vulnerable time for women when they're getting more comfortable with a new baby and they are going back to work. They're dealing with so many things. And many times pregnant women are, after they have the child, end up switching coverage. And when we look at the data, we find ways to advance health equity, for example, with the American Rescue Plan making postpartum care and expanding coverage through the Medicaid program. So that's just one example of how when we look at data to see what's happening, we can make better policies and improve our healthcare system for the people who it's meant to serve.
Well, during the pandemic, we also saw some major delays in routine care and routine screenings. I know that I've heard private payers saying in their quarterly earnings that this is an area they're watching closely because there's concern over future costs for sicker patients. How are you thinking about this potential future downstream cost, and what can CMS really do about it?
It's an incredibly important point. We definitely have seen that in the 2020 data that people may have put off care for what are probably obvious reasons. Again, I think that comes from a combination of making sure people have coverage. So when people know that they can go to the doctor and have access to care, they're going to be more likely to do that. We are certainly seeing advances in making care more accessible, and that's another important piece. So making sure that we're supporting the community, making sure that trusted partners are educating people about their options. And that will continue to be an emphasis of CMS, that we are working with stakeholders that are trusted partners to the people that are being served as a way to make sure that people are getting the care that they need.
Well, telehealth was one of the big solutions, obviously, that we saw really take off during the pandemic. And I know a lot of the questions in the industry are how will we ultimately preserve those gains? How do you characterize, what you see moving forward for telehealth and what the reimbursement should be?
It's a critical question. Telehealth had long been a discussion before COVID, and we all had a perfect laboratory of seeing what a difference telehealth can make. I've heard so much from certainly in my own life and from many members of Congress about how important telehealth has been to communities, particularly in the mental health space, and really making sure that people were able to seek access to care, get it during the pandemic, and what a difference it made in terms of hospitals, in terms of people showing up for their appointments. So telehealth remains critical. We have to think about how we make sure that people are getting access to the care that they're receiving. And so that's going to be an important piece that CMS will also be looking at as we look to make some of these policies more permanent.
And is that something that's within CMS's purview, or is that really going to require Congress to act as well?
There are some pieces of telehealth that CMS will have some authority, but Congress is going to need to act on some of the critical pieces to make telehealth permanent.
I wanted to move on to Medicaid. I know that you have deep experience working with states on Medicaid. What can you tell us about how you're working with states, in particular Republican-led states, to move, for instance, different like Medicaid expansion forward? And what is your thought process on working with the states?
It is critical in my mind for CMS to be very responsive to all of its partners, and states are key in that. As you know, states are the ones that administer the Medicaid program, and it's critical that we at CMS really make sure that we are keeping in mind the state perspective. I really have had such a an education in my prior life about how difficult sometimes it is for states to operationalize what's going on in the federal government. And that's why I'm so pleased that we are developing a team that really is going to have a state perspective. We are going to work and have an open door with all states, and on Medicaid expansion, really want to work with states to see that this is in their financial advantage. The American Rescue Plan really creates an incredible opportunity for states to expand the Medicaid program.
Well, I guess for states that are looking to not accept that funding, I guess what's the best way to move forward with them, or to gain cooperation, or I guess to get it to move forward? Is it working with carrots, sticks, hands-off approach, hands-on approach?
It's really important in my mind we know that that states will have different ideas about what they want to do, and we want to make sure in the Medicaid program that at the end of the day, we're really focused on what's best for people. And so I think I want to continue to work with states on developing care for their population. And if states choose not to expand, it is important that there be an option for people. And so really focused on, as the president outlined during the campaign, making sure that we're doing something in the coverage gap, and we're starting to see interest there from Congress.
If you had to pick one thing the Trump administration did right on healthcare, what would it be?
I think that the Trump administration has really wanted to focus on prescription drugs, and really tried to do that. That is certainly going to be a focus on this administration, to work with Congress to pass important, comprehensive prescription drug costs in this upcoming session.
I know Aduhelm has gotten a lot of attention recently. Is CMS going to make a national coverage determination on that?
CMS is looking at what the FDA has approved, and we will be reviewing all of that evidence and look forward to hearing from stakeholders on those pieces.
So, but obviously we're looking at a drug that could cost Medicare a lot of money, depending on how many seniors end up taking it. As CMS administrator, how do you plan on using your rulemaking authority to address prescription drug costs?
As we know, there are exciting, innovative products that are coming out of the pharmaceutical industry. And I mean, in Alzheimer's in particular, what a devastating disease. It is critically important, as you've raised, for us to address prescription drug costs. We hope to work with Congress. We have bipartisan interest in addressing prescription drug costs. As a former Hill staffer, I'm very excited about working with Congress to address prescription costs, and hope that we can do that this year.
Well, thank you very much, Administrator, for joining Axios today.
Thank you for having me. Have a good rest of your day.
You too. And up next, we have a View from the Top segment with my colleague, Chief People Officer at Axios, Dominique Taylor.
Thank you, Tina. Now joining us from Houston, Texas, Executive Vice President and Associate Chief Medical Officer at UnitedHealth Group, Dr. Margaret Mary Wilson. Welcome, Dr. Wilson.
Thank you so very much, Dominique. It's an absolute pleasure to be here today.
Dr. Wilson, can you tell our viewers a little bit about UnitedHealth Group, as well as the work that you're doing to shape the future of healthcare delivery and to improve access to care?
Certainly. UnitedHealth Group is an enterprise that comprises 330,000 team members. That's almost 1/3 of 1,000,000. And this is across the world. And each and every day, each of those team members wakes up dedicating themselves to truly help people live healthier lives and help make the health system work better for everyone. That's our mission. Simply put, we provide healthcare benefits through UnitedHealth. We serve individuals, employers, Medicare and Medicaid beneficiaries, and we also offer health services through Optum. Optum serves the worldwide healthcare marketplace, and we serve payers, care providers, governments, life science companies, employers, health systems. And in my former role, as Senior Vice President and Chief Medical Officer for UnitedHealth Global, I was the clinical leader for our clinically integrated benefits, services, and care delivery business. We have over 200 clinics and about 52 hospitals across the world, primarily in South America, and we serve more than 7 million people. At the core of our mission at UnitedHealthcare is sustainability. We consider that foundational to our business, our culture, and mission. And as you may be aware, Dominique, we recently released our annual sustainability report. And basically that rests on 4 pillars: helping, modernize the healthcare system, people and culture, responsible business practices, and environmental health. But most importantly, for the first time this year, we made firm commitments to 3 long-term commitments that we think are truly critical to transforming healthcare. The first is ensuring that 85% of our members will receive preventive care services annually by 2030. Second commitment is that more than half, 55% exactly, of our outpatient services and radiology services will be delivered in high quality, cost effective settings by 2030. And the third is that by 2025, we will close 600 million gaps in care for our members.
That is tremendous. What a great potential impact now and in the future as well. Moving to sort of the present day, we all know that COVID-19 has had a major impact on the healthcare industry. How has COVID-19 impacted how you look at access to care, and how have you addressed some of the challenges that surfaced because of COVID?
The COVID pandemic drove a significant pivot, I think, in the way we all view healthcare, and really gave momentum to the criticality and the urgent need for healthcare transformation. It revealed gaps in our healthcare system, but then it also drove fresh thinking around how we interact with patients, and also drove urgency around innovation. And we saw that happen with the vaccines and the advances that were made with vaccine development on the mRNA platforms. We have experienced globally the challenges around access. So we have a strong focus driven by the pandemic on expanding our access. And we believe that that is critical to modernizing the healthcare system, because every single person, regardless of their status group, should be assured of optimal quality, affordable care that meets their specific needs. And we are deeply committed to advancing this, not just in the United States, but across the world. Let me give you a few examples. When we think about expanding access to care, that's critical, right? It really is about connecting people to primary care and appropriate specialty care arising from that. We're leveraging digital capabilities for that. An example, simply, we believe that if you are able to link people to appropriate primary care, then everything flows from there: preventive care services, etc. One example is Optum's Able To. We've seen that mental health has been really critical, and we see challenges with that emerging post-COVID. So Able To is our platform whereby we're able to connect our members to licensed behavioral care providers, and we've shown good outcomes. The program has decreased inappropriate hospitalizations by about half, and has also reduced depression by half. We're also leaning into supporting the workforce. We know there will be an impending shortage of clinicians in the 21st century, and so we are supporting that. We recently donated $3 million to the University of Nevada to help support a primary care course curriculum. So bringing all this together, we believe that using digital capabilities and improving access to primary care will definitely make a difference. And the third piece is really around leaning into building stronger and healthier communities, not just by expanding access, but as I pointed out, by helping build a health workforce at the resident level, but also at the other clinician specialties. So you may be familiar with our Diverse Scholars Initiative. And since 2007, we've funded nearly 3,000 scholarships in that space. So those are just a few examples of some of the things that we're doing.
That's fantastic. Truly a very holistic approach, and interesting to hear how COVID has helped healthcare sort of accelerate its transformation, and we've seen that in other industries as well. As organizations continue to develop initiatives that address inequities in care, what is UnitedHealth Group doing in this space while also advancing health equity?
We have had a strong focus on health equity for more than a decade. And we have strengthened and we continue to strengthen our focus. You may have noted recently that a couple of days ago, the America's Health Ranking Disparities Report was released. And it still speaks to disparities amongst vulnerable populations, African American mothers, Black infant mortality. We still have those challenges. So one of our areas of focus is really about working with strategic partners to address these issues. A couple of examples of some of the work that we've done. We recently worked with community health workers in Hawaii, Michigan, and Ohio. And this was within our United Healthcare community and state health plans. And we have shown that working and designing culturally appropriate, focused interventions were yielding really great results. Our work, a collaborative work, has shown an 83% reduction in healthcare disparities amongst Black women in Ohio related to postpartum care. In the same population in Michigan, we were able to show a 42% reduction and a 40% reduction amongst women living in Hawaii. So bringing all this together, we continue to have a strong focus on health equity and are really leaning into decreasing healthcare disparities amongst our population.
That's incredible. Some great results there, but still a lot of work to be done. And grateful that you are here with your leadership and doing this work. Thank you for this wonderful conversation, and thank you for everything that you do.
Thank you so very much, Dominique, for having me. It's been an absolute pleasure. And thank you for what you do as well.
And now to my colleague, Sam Baker.
Thanks, Dominique. I'm Sam Baker. I'm a senior editor here at Axios. And our final guest today is the representative for California's 7th Congressional District, Representative Ami Bera, joining us from Washington, D.C. Congressman, thanks so much for taking the time today. Really appreciate it.
Sam, thanks for having me on.
So when we're talking about care delivery and the future of care delivery, we know, we get new data almost every day about the amount of care that people put off during the pandemic. Some of that was screenings, some of that was actual treatment. We know routine vaccinations are way down. So just to sort of, as a starting point, how do we get back to normal on the care that we've already missed out on? And at the same time, we weren't that healthy of a country to begin with. So is getting back to normal good enough?
It probably isn't. So I think, Sam, that's a great question, because so much of the last year and a half has really been focused on the pandemic and protecting the public health, and then the last few months really on the vaccination efforts. Obviously, we still have a ways to go on getting vaccines to those harder to reach populations. But as you rightfully pointed out, there was a lot of routine healthcare that did not get taken care of: cancer screenings, vaccinations, just general physical exams. So there is going to be this pent-up demand that potentially overwhelms the system as we come out of the pandemic. Factor on top of that you've got a healthcare workforce that really was stretched thin throughout the pandemic, that is feeling the effects of burnout and the things that they had to see. So we do worry about the potential of retirements in that workforce. So we've got to figure out how to work through this backlog of necessary care. And then we did see in the pandemic some trends that were already happening, but things that we don't want to go away, like telemedicine, audio visits, et cetera, that really did provide access to care through the pandemic. Those are all good things. Democrats and Republicans want to see us continue to fund and make more readily available those things. We've got to figure out how to pay for it and what that looks like.
So telehealth, which you mentioned, is sort of seen as one of the silver linings is probably too strong. Things we did right that we'd like to continue doing. Are there any other sort of interventions in that category in your mind? Things that you'd like to keep going?
I think a few other things. We have this unique opportunity to build up our public health infrastructure. We certainly saw how public health and county health departments and state health departments really hit atrophy pre-pandemic, which left us in a challenging place to address the pandemic when it hit. Now we're throwing billions of dollars at building up public health departments through the vaccination efforts, et cetera. Let's actually build a public health department and public health infrastructure in America that we deserve. And that'll help us deal with community-based issues like other infectious diseases, vaccinations, clean water, clean health, et cetera. Those are measures that are hugely important that can have real impact. So as we're spending these billions of dollars, let's also be strategic about building up the public health infrastructure in America.
And on the, specifically on the delivery side and sort of outside the context of a crisis or a public health emergency, when we sort of think back to normal healthcare needs, so telehealth is one thing that everyone wants to keep going. There are obviously a lot of gaps that can't fill for all of the value it does have. A healthier country is just going to have more people seeing providers. And some of the obstacles to that, some of them are super local, as you've seen up close. Some of them are hugely structural. And so, I wonder if this is that sort of a shift that Congress can generate, or, are you sort of more on the edges?
I think we can facilitate some of that shift, and how we do that is obviously we're appropriating lots of funds to states and counties through the ARP, the American Rescue Plan. We also have, the pandemic really exposed what was already there in terms of real healthcare inequities, particularly in communities of color and less resourced communities. And then, the fact telehealth, telemedicine was great for a lot of folks, but a lot of communities don't actually have broadband and access to those tools. So I do think Congress has a role working with the Biden administration as we put together this infrastructure plan. Can we address that broadband access? Because again, I don't think that's going away. I think those trends are actually going to continue. And then can we really address the healthcare inequities, the communities that really do have lack of access and lack of regular access to healthcare? The Biden administration talks about healthcare equity. They obviously have a position in CMS and HHS to address equity issues. So I do think there's an opportunity to get to these harder to reach communities and try to build some infrastructure there.
Anytime we sort of want more of something in the healthcare system, the way to get it is to throw some money at it, right? Like we got more telehealth because we changed some of the reimbursement rules around telehealth. We want more primary care providers. So I know you've been involved in this, and there's a lot of members, I think, with bipartisan support who want to change the reimbursement for primary care to make that a more lucrative specialty. Usually that seems to work. At the same time, we have a healthcare system that costs $3 trillion a year. How do we sort of change these incentives without just ending up with a healthcare system that costs $4 or $5 trillion a year?
Yeah, so we really do have to address the cost of healthcare. I think you will see Congress try to address pharmaceutical costs. I think there's probably a sweet spot in the generic space where hopefully you can put together both Democrats and Republicans to address at least the generic cost of medications and bring those down. That certainly could be tens of billions of dollars in savings. I do think some of the price negotiation pieces, there were things that the Trump administration did in terms of negotiation and reference pricing that, some pieces may stay in the Biden administration. That'll be a little bit harder. You've seen market consolidation both in the hospital and health plan space, so it'll be interesting to see how that gets addressed and, are those cost drivers? And then, what is that right balance between primary care and specialty care, and what does that reimbursement model look like? My sense is we'll move in a direction of more value-based contracting where we're shifting more risk onto the hospitals, the providers, the health plans, saying, here's what that capitated payment looks like. You figure out the best way to address and deliver that cost of care. And there were some trends pre-pandemic that were moving in that direction, based on the ACA, et cetera. I think you'll continue to see a move in this value-based direction.
So on drug prices, it's a little bit more complicated sometimes once you sort of start getting into the weeds. There's obviously a lot of some of these leading edge cancer treatments, for example, even the experts who try to put a real value on drugs say, well, this is pioneering science, and sometimes that stuff's expensive. Then you also have, drugs that don't seem to work that come on the market at an incredibly high price point, old drugs with big price increases. How do you go about sort of thinking about what's the right tool to apply here to get all the right outcomes?
Yeah, that's an issue that we've been working on for a while. So you see these remarkable gene therapies that, in the oncology space that are not only life-saving, but disease-altering, but they're coming with a really big price tag. So, in the commercial sector, they'll go into risk-sharing contracts that say, okay, we'll pay the big price on the front end, but it'll get paid over a 5-10 year period. And there's going to be shared risk. If that cancer comes back and the therapy doesn't do what it's touted to do, well, then, some of that payment's going to come back to the payer. I think we've got to think about that model in the Medicare, Medicaid space, particularly for these high-cost gene therapies. I also would love to see the CBO, the Congressional Budget Office, score some of these things. So, yeah, maybe we're spending $300,000 on the front end to cure sickle cell anemia, but how many hospitalizations are we going to avoid? What's the true cost of curing this disease and the cost avoidance? And that's how we would look at it in the commercial sector. I think that's how we have to look at it in the government sector for Medicare and Medicaid patients.
Fair enough. Okay, well, I think that is our time. You have been generous with yours. So thanks again for joining us. It was great to speak with you.
Thank you for having me on. And again, happy to do it again.
And thank you for joining our Vitals Checkup series this afternoon, which has made everyone smarter, faster. And thanks again to UnitedHealth Group, our sponsor for today's event, for making this conversation possible. For more information and to stay on top of all the day's healthcare news, please subscribe to Vitals, our morning healthcare newsletter, and the namesake for this series, of course. You can do that at axios.com/newsletters or in the Axios app. We will see you there, and we will see you next month for another Vitals Checkup event. Thanks again for joining us. Have a great day.